Introducing Drs. Gabriel Contreras and Dr. Leonardo Tamariz. Dr. Tamariz is an associate professor in our Population Health and Computational Medicine Division and a clinical investigator in the Division of General Internal Medicine here at the University of Miami. Dr. Tamariz completed his residency at the University of Miami and a clinical research fellowship, as well as an MPH from the Bloomberg School of Public Health at Johns Hopkins University. His research interests include the use of claims data for the identification of healthcare disparities and recruitment into clinical trials. He is particularly involved in identifying elderly hypertensive patients without diabetes or stroke for the SPRINT trial. Apart from this, he is also the research director for our internal medicine residency program, chairperson of the IRB Review Board at the Miami VA, and the deputy editor for the Journal of General Internal Medicine. Dr. Contreras is a professor in the Division of Nephrology and Hypertension. He earned his medical degree in 1984 from the University of Guadalajara in Mexico. He has since trained in internal medicine, nephrology, hypertension, and critical care, and earned an MPH between 1989 and 2003. In 1995, he joined the School of Medicine at the University of Miami. During his time as faculty in the Department of Medicine, he's been involved in the development and establishment of a successful clinical research program here in our Division of Nephrology, with 24 research grants, 82 publications, and 6 chapters. He keeps research funding from the Kidney Foundation of South Florida, as well as the NIH. And he's currently funded by the NIH as a site principal investigator for the Systolic blood pressure intervention SPRINT trial, which results will provide guidelines to treat hypertension. Please join me in welcoming Dr. Contreras and Dr. Tamariz.
Well, thank you very much for the kind introduction. Let me start then. So we're going to today review the systolic blood pressure intervention trial, the SPRINT, and how this study is changing, the target systolic blood pressure in adults. We're going to review with the objectives are to assess the rationale, the goals and study design, to evaluate the efficacy and safety of the SPRINT trial interventions. We're going to also examine the results in subgroups, particularly the senior subgroup in the study. And we're going to assess how cost-effective is the SPRINT treatment strategy. And we're going to also assess the opportunities that a multi-center clinical trial brings for subsequent, clinical research. These are the disclosures that were made already. Let me start with the background and rationale. High blood pressure is the leading risk factor for mortality and disability adjusted life years. And there are more than 1 billion adults with hypertension. Now, what we know from observational studies is that the relationship between blood pressure and cardiovascular events is linear and has no threshold. And what we know also from clinical trials done in the last 60 years or so is that treatment intervention reduce the risk of cardiovascular disease and renal events as well. But what we don't know is what is the target blood pressure. And that's one of the main goals of the SPRINT. Now, these graphs illustrate the results of the largest meta-regression study that enrolled about 1 million people. And what you can see here is that the relationship between systolic and diastolic blood pressure and the absolute mortality for ischemic heart disease is essentially linear, has no threshold. And even and that you can see also is that even with systolic blood pressure below what we call normal, 120, there is still reduction in the risk of cardiovascular events, and in this case, ischemic heart disease. Another finding of this slide is that you can see that the effect that systolic blood pressure has compared to diastolic is much stronger. You can see that all these regression lines are shifted a little bit up. Now, this graph illustrates that in adults at the age of 50 or older, what really rises is the systolic blood pressure and not the diastolic blood pressure. And the prevalence of systolic hypertension is much higher than diastolic hypertension. Now, the SPRINT research question is to examine the effect of more intensive high blood pressure treatment than currently recommended. The design is a randomized controlled trial that include two groups, the intensive goal or treatment group, where the goal was to bring the systolic blood pressure less than 120, and the standard goal group is to bring the systolic blood pressure less than 140, the control group for the study. Now, adults 50 years of older were included with systolic blood pressure at baseline between 130 and 180, and at least one additional cardiovascular risk factor. Clinical or subclinical history of cardiovascular disease or chronic kidney disease, defined as an estimated glomerular filtration rate between 20 and 59, or a Framingham risk score for 10 years cardiovascular disease event of at least 15%, or age 75 or older. These are the major exclusion criteria: patients with history of stroke, diabetes, PKD, congestive heart failure with ejection fraction less than 35%, patients with proteinuria chronic kidney disease of at least a gram or more, or advanced CKD, or poor adherence were excluded from the study. Now, these graphs illustrate the enrollment. There were approximately close to 15,000 people screened for the study, and 9,361 were enrolled. 4,678 to the intensive treatment group, and 4,683 to the standard treatment group. What you see here in this table is some of the baseline demographic characteristics. The mean age of the population was 68 years old, 28.2% were 75 years of older, 35.6% were female, 57.7% were white or Caucasian ancestry, 29.9% were African Americans, 10.5% were of Hispanic ethnicity, 20.1% had a prior history of cardiovascular disease, 20.1% had a high risk score using the Framingham system, and 90.6% were taking antihypertensive when enrolled. Now, the mean number of antihypertensive that they were using was about 2 antihypertensive, 1.8, and the mean systolic blood pressure at baseline was 139.7 and diastolic of 78.1. All these baseline characteristics were balanced between the two groups. Now, here you have some other baseline characteristics. The mean eGFR was 71.6. 28.3% of the participants were categorized as chronic kidney disease with an estimated GFR of less than 60. The mean urine albumin creatinine ratio was 42.6. The mean total cholesterol 190, and the mean fasting plasma glucose was 98.8 milligram per deciliters. There were 6 pre-specified subgroups of interest in the subgroup analysis: age less than 75 or older, gender, men, females, in ancestry, African American compared to others, CKD compared to non-CKD, history of cardiovascular disease compared to no history of cardiovascular disease, and the level of baseline systolic blood pressure stratified by tertiles. Now, the primary outcome of the study was a composite outcome. The first occurrence of a myocardial infarction, acute coronary syndrome, stroke, acute decompensated heart failure, or a cardiovascular death. The primary hypothesis was that the cardiovascular disease composite outcome event rate would be lower in the intensive group compared to the standard treatment group. The study had a power of 88.7% to detect a 20% difference, assuming an event rate in the control group of 2.2% per year, and assuming a follow-up of 4 to 6 years with a loss of follow-up of about 2% per year. There were other additional outcomes: all-cause mortality, the composite of the primary outcome plus all-cause mortality. There were 2 renal outcomes. The main secondary renal outcome was assessed in the participants with CKD at baseline, was a composite of the incidence of decline in eGFR of 50% or more, or development of end-stage renal disease, the need for dialysis for a kidney transplant. An additional secondary outcome, renal outcome, was in participants without CKD was a decline in the eGFR of at least 30% with a value less than 60. And there was also another renal outcome, which was the doubling of urine albumin to creatinine ratio, or the incidence of albuminuria, and those that they have a normal albumin excretion rate at baseline. Now, the cuff size determination was standardized in all the clinic. All the clinic used the same system, an automatic system. All the patients at baseline and every year had their arm circumference measured, and the appropriate cuff was used. After 5-minute rest, 3 automatic blood pressure measurements were taken, 1 minute apart, and the mean of the 3 was used to change the therapy. Orthostatic hypertension was assessed at baseline, at 1 month, at 6 months, 12 months, and then every year thereafter in the clinic visits. The clinic visit included the follow-up was a baseline. After baseline, the patients were brought to the clinic every month until month 3, and then every 3 months thereafter, unless there was need for titration of the medication to achieve the goal. Now, what you see here is the sprint treatment algorithm that was used in the intensive treatment arm. If at the visit, the systolic blood pressure was 120 or higher in that group, and we were dealing with the mild post-visit, those are the every 6-month visit, the investigator was required to add a new antihypertensive or titrate up the current antihypertensive and bring the patient monthly until the systolic blood pressure was at goal or less than 120. If this was not a mild antihypertension, it was recommended that the medication is titrated up or add a new antihypertensive and follow the patient every month until the systolic blood pressure was at goal of less than 120. If the diastolic blood pressure was 100 or higher during that visit, or 90 or higher in the last 2 consecutive visits, it was required that the investigators titrate the antihypertensive to achieve adequate control of the diastolic blood pressure. This is the algorithm that was used in the control group, the standard treatment group. If the systolic blood pressure at that visit was 160, or in the last 2 consecutive visits was 140 or higher, then the investigator will require that they titrate the antihypertensive or add another antihypertensive and bring the patient every month until the blood pressure was controlled or less than 140. If the diastolic blood pressure was 110, 100 in that visit, or 90 in the last 2 consecutive visits, investigator would require that they also titrate the antihypertensive medication to achieve good control. If the systolic blood pressure was then 130 in that visit, in that group, or less than 135 in the last 2 consecutive visits, it was recommended to step down in the treatment to allow the pressure to increase a little bit. Now, what you see here in this graph is the systolic blood pressure during follow-up. Very rapidly, with that strategy, there was very nice separation in the, between the 2 groups. The average systolic blood pressure in the standard group was about 134.6 millimeters of mercury, and the intensive group, 121.5 millimeters of mercury. The mean number of antihypertensive required in the control group were 2. The mean number of antihypertensive required in the intensive treatment group were 3. More antihypertensives like diuretics, ACE inhibitors, and calcium channel blocker were used in the intensive group compared to the standard group. It was recommended in the study that first-line antihypertensive, the one that we know are more potent and more effective, were used initially. And those are the ones in those categories: angiotensin converting enzyme inhibitors, angiotensin II receptor blockers, calcium channel blockers, or diuretics. It was also recommended that the antihypertensive regimen also include antihypertensive based on the clinical history of the patients. Beta blockers for patients with ischemic heart disease, ACE inhibitors are for patients with chronic kidney disease. In August 2015, the Independent Data Monitoring Committee informed and recommended to the chair of the steering committee to stop the study because significant difference was observed by that time. The study by then had a follow-up, a mean follow-up of approximately 3.26 years. And what you see here in this graph, in the y-axis, is the cumulative hazard. There was a significant reduction in the risk of the primary composite outcome with a hazard ratio of 0.75, a 25% risk reduction, comparing the intensive group to the standard group. 243 events were tabulated in the intensive group compared to 319 events in the control group. The number of patients needed to treat with the intensive strategy was calculated to be 61 to reduce one composite cardiovascular outcome. What you see here in this table is the rate of events, the number counts of the primary outcomes, and also the individual components of the composite outcomes. In the primary outcomes, the rate percentage of events per year of follow-ups in the intensive group was 1.65% compared to 2.19% in the standard group. When we look at events, ischemic heart events were the more common when we group together myocardial infarction of acute coronary syndrome, followed by strokes, congestive heart failure, and cardiovascular death. Only events of cardiovascular failure and cardiovascular death were significantly different comparing the intensive to the standard group. But all the other events had the same trend favoring the extensive treatment intervention strategy. What you see here in this forest plot is the subgroup analysis. And you can see that the results were very consistent with the primary outcome. The results were very homogeneous in all the subgroups, favoring the treatment of intensive systolic blood pressure control compared to a standard blood pressure control. This graph illustrates the cumulative hazard of one of the most important secondary outcomes, all-cause mortality. Again, a significant benefit was achieved in the intensive group compared to the standard group with a hazard ratio of 0.73%, a 27% risk reduction. 155 deaths were tabulated in the intensive group compared to 210 deaths in the standard group. The number of patients needed to treat with the intensive strategy was calculated to be 90 to reduce one all-cause mortality in the trial. What you see here in this table is the cause specific of death. When we talk about cardiovascular death, there were 18 deaths in the intensive group, 32 in the standard group. Most of the deaths, cardiovascular deaths, were related to ischemic heart disease, followed by stroke and congestive heart failure. 37 deaths occur in the intensive group, 65 in the standard group. When we look at the non-cardiovascular death, 90 occur in the intensive group, 102 in the standard group. The most common cause of death was cancer-related, very similar in both groups, 49 in the intensive group, 52 in the standard group. Now, what you see here in this table is the renal disease outcomes. In the upper panel, you see the primary chronic kidney disease outcome in the patients with baseline CKD. 14 events occur, the composite of decline in estimated GFR of at least 50% of end-stage renal disease, 40% in the intensive group, 14 events in the intensive group, 15 in the standard group, no difference. When we look at incident albuminuria in that group, there was no difference again. In participants without CKD at baseline, when the secondary outcome of declining GFR of at least 30% and less than 60, more events occur in the intensive therapy group with a rate of 1.21 events per year of follow-up compared to a rate of 0.35 events per year of follow-up in the standard group, with a hazard ratio of 3.48, a significant value with a 90% confidence interval that doesn't include 1. Incident albuminuria was very similar in that subgroup of patients without CKD. Now, what you see here in this table is the serious adverse events comparing the two groups. Very similar. At 38.3% serious adverse events were tabulated in the intensive group, 37.1% in the standard group, no different. There were pre-specified serious adverse events of a special interest: hypotension, syncope, injurious falls, bradycardia, electrolyte abnormality, and episode of acute kidney injury. When we compare the two groups, there were more hypotensive episodes in the intensive group with a rate of 2.4% compared to 1.4% in the control group. There was also more syncope event with a rate of 2.3% in the intensive group compared to 1.7% in the control group. Falls have a very similar rate between the two groups. Bradycardia, very similar rate. Electrolyte abnormalities, there were more events in the intensive group, 3.1% compared to 2.3% in the standard group. An episode of acute renal failure were more common in intensive group with a rate of 4.1% compared to 2.1% in the control group. This table illustrates the electrolyte events that were significantly that were important and were a priori followed closely. Sodium less than 130, which was the definition used for hyponatremia, occurred more commonly in the intensive group with a rate of 3.9% compared to 2.2% in the standard group. Potassium less than 3 occurred more commonly in the intensive group with a rate of 2.5% compared to 1.5% in the control group. Now, all these electrolyte abnormality correlated more with the use of more diuretics in that group. Now, from the public health implications of the SPRING findings, now what you see here in this slide is a summary of the data, the pooled data from the last NHANES surveys in this country. There are approximately 16.8 million people that qualify to enter the SPRING from the USA population, 7.6%. These are patients that they fulfill the entry criteria of SPRING, and they didn't have any exclusion criteria. From them, half of them are receiving treatment for hypertension, the other half are not. With this amount of patients at risk in this country, 60.6 million at risk, and the calculated number needed to treat of 61 with the intensive treatment strategy of SPRING, we can prevent approximately 410,000 preventable cardiovascular events, with the number of needed to treat to prevent all-cause mortality of 90. We can prevent about 186,667 death with the findings, extrapolating the findings of the SPRING. Now, I'm going to move now. I'm going to let then Leo continue the presentation, and we're going to answer the question at the end.
So, can you hear me with this thing? Yep. So Dr. Contreras has told you a couple of interesting facts. One, we got the blood pressure very quickly to 120 or so, but we never got to the number that we wanted to get, which is less than 120. It was difficult for us to get there. We saw the patients monthly, sometimes even more often. The study showed that there was a large reduction in the primary outcome and a large reduction in deaths. So this is a beneficial study. But at the same time, we did it increasing slightly the number of acute renal failures. And you're going to see soon a publication on the kidney part of the study that shows that some of those kidney failures were reversible. And it was a small number, yeah. Dr. Contreras also told you that we had to stop the study early, about a year earlier. So we were unable to see the events that we were trying to see at the 5th year, which is mostly the cognitive function, because obviously we are keeping people alive longer. We might have increased a little bit kidney failure, but at the same time, we wanted to make sure that that cognitively these people were doing fine. So those are the initial points from this study, the take-home points from this study. So I wanted to start with a case which sort of illustrates the challenges that we have when treating people with hypertension. And the specific challenge is that of the elderly. 79-year-old woman with a history of hypertension, repeated high systolic blood pressures that, according to guidelines when we started the SPRINT study, actually should have been lower. Compliant with her meds, obviously a very important question to ask. Does the right thing, exercises, doesn't smoke, and is independent. She does not have diabetes or stroke, so she fits the criteria of SPRINT. Her total cholesterol is high, HDL is a little low, and her Framingham score is 22%, so high risk. So again, fits the criteria of SPRINT. There are many interesting questions that we can actually ask from this case, but I wanted to concentrate on 4. And the first one is actually logistic. When we started the study, my first concern was, can I find an elderly patient who doesn't have diabetes but has hypertension and doesn't have a stroke? So that was my initial concern. So I want to try and answer that question. Second, the probability of people specifically this group, the elderly, having orthostatic hypotension. Third one is, what is her ideal SBP goal? And you can guess that one from what Gabriel has told you. And fourth, I wanted to focus a little bit on an unpublished study that we just sent for publication, which is the cost effectiveness of the SPRINT SBP goal. So the first question, how did we recruit this group of patients? So elderly, hypertensives with no history of diabetes or stroke. So Gabriel and I did a small study within the SPRINT study where we try to identify these people at the VA, because at the VA we have the electronic system that helped us do this. So we created an algorithm where we identified people who were more than 75 years old, who had an ICD-9 code, for hypertension, 405 or 401 or 405, who did not have ICD-9 codes for diabetes and did not have ICD-9 codes for stroke. We created this algorithm, run it through the computer at the VA, and we were able to identify people for our study. And we actually had a large list of people who could be eligible for the study. During this study, we found out that the hypertension, the positive predictive value of having an ICD-9 code for hypertension is actually fairly high. So people that had the ICD-9 code truly had hypertension, and that's expectable. But the nice thing is that when you use the entire algorithm, we were able to identify a lot of people who had this profile of patients that we needed to recruit into the SPRINT trial. So the PPV, the positive predictive value of the entire algorithm, was 83%. So we validated this algorithm to the medical record in a small sample of our veterans, 76 people. You can see that these were elderly patients. Obviously, we did this at the VA, and the majority were male. Surprisingly, 89% white race, and they had several comorbidities. So the point that I want to make here is that electronic medical records can help you find people who are difficult to find for clinical trials. So I want to spend a little bit of time on the elderly group. So for the next 4 to 5 slides, I'm going to talk about the outcomes of the elderly group, the greater than 75 years or older. And they're fairly similar. When you divide them into the 2 randomized group, intensive and standard, you can see that we had 1,300 patients. The mean age was fairly similar to the case that we actually presented to you. A third of them were female. Interestingly, only about 25% were minorities. We were shooting for a little bit higher number. The mean Framingham risk score was 24, These people were taking about 1.9 blood pressure meds to control their blood pressure. The next question that I wanted to tackle was the issue of orthostatic hypotension. And this recently published study was done on a smaller sample, not the entire sample, the 9,000 people, close to 9,000 participants of Sprint at baseline. So at the beginning, before we actually did anything to them. And this histogram shows you the distribution of the blood pressures. 0 means that there was no difference between sitting and standing. Any number that's negative to this side shows you that when you go from sitting to standing, your blood pressure would drop. Any number that's positive shows you that when you go from sitting to standing, your blood pressure would increase. So you can see that the majority of the distribution goes to this side. So that means that your blood pressure would drop. And you could say that about 7% of the population actually dropped 10 millimeters of mercury, their blood pressure. And about 4% 20 millimeters of mercury. So before we actually did anything, there was some orthostatic hypotension. And this is an important statement to make because of something that I'm going to mention later. So if you take the entire group of people, the 8,000 people, you're going to see that about 7% had orthostatic hypotension before we even touched them. And then you can see that that 7% was distributed, as Gabriel said, in less than 75 years old, the majority. But if you actually do the numbers, the calculations, you will see that the majority of the patients that had orthostatic hypotension were the older. So 9% of the greater than 80, 9% of the 75 to 79 years of age actually had orthostatic hypotension. And again, this is before we even touched them. In this group of patients, the 75 years and older, we found similar results to what you just saw. There was a 33% reduction in the risk of having the primary outcome when you reduce blood pressure to 120 or less, systolic, compared to the standard arm, which was the guideline-based number. And all-cause mortality, there was a 34%, 33% in all-cause mortality, and those numbers were statistically significant at 3-point-something years of follow-up. If you actually look at what drove this result, it was actually a little different than what Gabriel showed you. It was mostly heart failure. So it wasn't myocardial infarction like in the main study that Gabriel showed you. It was all heart failure, and it wasn't cardiovascular death. There are some p-values that might be interesting there, but it mostly driven by heart failure. So in the elderly, the reduction is due to the reduction in heart failure, the reduction in the primary outcome. There's no debate that it actually reduces all-cause mortality. CVD death, it does not reduce. One of the interesting things that Sprint did was to measure frailty. But frailty wasn't measured in the original way that it was developed. Now, we measure frailty using grip strength and a couple of other things. Because we didn't plan for this, Sprint did it in a different way. To do this, we used the 36-item frailty index based on PHQ-9, based on cognitive function, and a couple of other items like comorbidities, and even blood pressure. And obviously, we had to validate this frailty index. And compared to the other frailty index that are out there, it did correlate somewhat with age. Obviously, if you want, with age, we become more frail, so you want to see this curve going up like the other curve. So it did correlate somewhat. It wasn't perfect, but that's what we had. And it did correlate with hospitalizations. It did correlate with other elderly outcomes. So we divided the outcomes in the 75 years and older by frailty. So no frailty on this side, high frailty on this side. And you can see that there is a reduction. First of all, you can see that if you're frail, you're going to have more outcomes. And so that validating the frailty index. But at the same time, if you're frail, there is a reduction in the risk of having the event in every category, but it wasn't significant in the non-frail and the frail. It was only significant in the middle frailty index. So that might have been related to the fact that we didn't have a perfect frailty measurement. In gait speed, there was no correlation. In both slow people and faster people, we found a reduction, statistically significant reduction in outcomes and this is the primary outcome for those who were slower and faster. I want to spend a little bit of time on the adverse events of the 75-year-olds and older, particularly because of what I said. That at the beginning we started with orthostatic hypotension. Maybe about 7% had orthostatic hypotension. Look at what happened when we followed these people for 3 years. Orthostatic hypotension was less. This might have been related to the medications that we use, but it's an interesting aspect that actually nobody has started to look into, which is interesting because of what I'm going to say in a couple of slides. So a little bit more orthostatic hypotension in the intensive group compared to the standard group, but not significant. And again, remember, this is the elderly population. If you look at all the other adverse events, they're non-significant. Again, keep in mind that the sample size here is smaller, so you would tend to have non-significant numbers. But the magnitude of the effect isn't that impressive. If you actually look at the adverse event by frailty and by gait speed, there was people who were frail had a little bit more adverse events, serious adverse events, and a little bit more adverse events those who were slower by gait speed, but it wasn't statistically significant. So those two aspects didn't correlate that well with blood pressure goal. So I'm going to shift gears now. So the point that I wanted to make with all those slides is that similar results were seen in the elderly. So this fear of treating the elderly person and having this fear of them falling, it might be real, but it didn't show in SPRINT. We might debate if other studies have shown it, but in SPRINT it didn't show. So this is unpublished work. Adam Bress is the person who's leading this with a group of us in SPRINT. And the research question here is doing the SPRINT, if you want to implement the SPRINT trial, is it cost effective doing it? And to do this, we run 1,000 simulations, micro simulations. So it's not a Markov model or any other type of decision analysis. This is micro simulations in which we took the actual SPRINT data. So we divided everyone according to the study, so intensive and standard. We calculated transitions into health states, and these are the health states, particularly into three things. One, cardiovascular events, like unstable angina, myocardial infarction, stroke, and heart failure. And we didn't use data that came from other studies. We used data from SPRINT to calculate those event rates and probabilities. The second one was adverse events. So the nice thing about this is actually we're taking into account the fact that we did cause an increase in kidney failure, and we're taking it into account into the cost effectiveness analysis. And obviously, we took into account death. And as in any type of decision analysis, what we try to do is we try to calculate the quality adjusted life years and the incremental cost efficient ratio, which I'll show you now. So this is the main result. As I said, it's unpublished. It's been sent for publication. We don't know if it's going to be accepted or not, but I wanted to show you the results. What is so cost effectiveness analysis? The nice thing or the interesting aspect of this cost effectiveness analysis is that we actually took into account adherence to the results. And we created 4 scenarios, which I'll explain in a second. But to calculate the cost, we use CMS data, inflated for 2016 cost data, and these are the costs. These are the assumptions that we did. This is the only extraneous data we use for the cost effectiveness analysis. We then calculated the QALYs, the quality adjusted life years. 1 QALY means that you have 1 year of perfect health. 0.5 means you have half a year of perfect health. And we did then the ICER, which is the incremental cost efficient ratio, which is just a fancy term to say that we divided cost by QALYs. And we estimated the probability of the study of the intervention to be cost effective if a health payer was willing to pay $50,000 for QALY. So these are the percentages. As I was saying, we did an interesting thing here, which is the adherence to the results or to the study. So the first scenario, which was the initial one, the base scenario, we assumed that people were adherent into the study until 15 years, and that there obviously was a decay, and that this decay in adherence happened in both arms. It's the same. Second scenario, there was no adherence after 5 years of the results. Third scenario, there was perfect in-trial adherence for 15 years. And the fourth scenario is that there is lifetime trial adherence. And you can see that as a higher quality obviously would give you better quality of life, better life. So the higher qualities were seen when there was more adherence to the study, and the ICERs were lower. That's what you want. You want lower ICERs to so less. You have to pay less for one quality, and the probability of being cost-effective increase. So the intervention is cost-effective if you adhere to the results. And this is an important point that I'm going to show you now. But before I do that, I wanted to show you, I wanted to propose an idea to everyone here, Gabe and I. And that's that, we're writing several proposals. We were part of writing papers for Sprint for many research questions. And as you know, there's a movement now to share federally funded data. So if there is federally funded data, that data has to be shared. And that there's a large movement towards that. These are the number of proposals submitted by Sprint investigators and that are currently being done. And you can see that the majority of the proposals are about disease correlates, so CKD, lots about CKD, lots about the heart. Clinton Wright is doing a lot of the cognitive and MRI results. I'm doing quality of life and cost. There's few about adherence, and there's few about minorities. So if you're interested in using the Sprint data, you can submit a proposal through us, and we can submit it internally to Sprint. But if you don't want us, Gabriel and I, to be a co-author in your paper, and you want to do this on your own, the New England Journal of Medicine has done something unprecedented, which is taking what the government has said, or what the feds had said, that the data that is publicly funded has to be shared. The New England Journal of Medicine is sharing Sprint data now. So if you want to do a study on using Sprint data, the only thing you have to go is go to that website, challenge.newenglandjournalofmedicine.org, and you can submit your proposal. And you can use Sprint data on your own time. Yeah, you download it into your computer, and you can use it. So if you have an idea, I would urge you either to submit it through us or go directly to the data. And because through us, you would have to get a biostatistician in the Sprint Center. It takes time. But if you want to do it today, as of yesterday, they're receiving Sprint data challenges. OK, so two more ideas, and then I'll finish for questions. The first one is just to go back to what Gabriel said. Gabriel said that we have 219 million people in the U.S. About 5.8 of those 219 million are actually elderly, so greater than 75 years old, and fit the criteria for Sprint. So if you did the numbers, the calculations based on the number needed to treat, there are a ton of preventable events that you could prevent. For both, for the primary outcome or for deaths. So if you believe the Sprint results, and if you're interested in doing in applying Sprint, you could do some good work based on public health estimations. So this is the reason why the trial adherence was important in cost effectiveness analysis. And so here what you have is data from our Miami VA. And what I've done is divided the standard and intensive care group. And you can see that when we finished the study, this intensive group obviously had more blood pressure meds. Their blood pressure was so-so. It was supposed to be less than 120. We got to 123. But this was at the end of the study. They were satisfied. We had an independent person call them, because if me or my research assistant would have called them, they would have said, oh yeah, we're satisfied. But we had an independent person call them and ask them, are they satisfied with their treatment? And they said they were satisfied. But look at what happened when we sent them into the real world. and I'm not faulting the PCPs at the VA. Look at the number of meds after 3 months in the intensive group. Went from 2.5 to 1.8. Look at their blood pressure 3 months and 6 months. So everything that we had gained, we lost in 6 months. And look at the satisfaction, especially the satisfaction in the intensive group. So I understand that it is difficult to apply the SPRINT results and to try and do SPRINT in your clinics. But this was very disheartening. So hopefully we can talk to the chief of staff at the VA and try and see if we can remediate this a little. So in summary, I'll repeat my opening remarks. You can decrease blood pressure to the level that we try to do. We didn't get to less than 120. We got to 121. It is difficult to do it. We had to see them often. We did do this at the cost of some increase in adverse events, particularly the kidney adverse events. And an interesting idea for those of you who want to do this type, I noticed that the increase in adverse event happened in the summer. So it might have been related to diuretics and the heat outside, for example, in Miami, at least in Miami. So if anyone wants to take that research question, easily done. We had to stop the trial because of the benefit. The benefit was impressive, and we had to stop at 3.26 years. And unfortunately, we couldn't see the cognitive events. There is a grant now to try and see if we can expand it to the 5th year and try and repeat MRIs and do the cognitive evaluations. But we don't know if it's funded or not. We will know until February. And there were impressive reductions in the risk of the primary event and the intensive, in the primary event and all-cause mortality and CVD. The number needed to treat for both outcomes was actually pretty good. 60 is decent. The cost, it is a cost-effective intervention to do, but at the same time, I do recognize that it is a difficult intervention to do if you want to implement it in your clinics. And there is an increase, as I said, in kidney disease. We'd really like to thank the people who participated in SPRINT, the funding agency. This was an interesting study for me because it wasn't a grant. It actually was a consortium of people who got together and said, we need to do this for the health of the country. And we participated in this interesting study. But particularly, we want to thank the people who actually did the majority of the work, which were our co-investigators and research coordinators at the VA and the university. We had 2 sites. The reason why we had an MRI site here was because we had 2 sites. So I think it's a great advantage for everyone to take advantage of this 2-site issue of having the Miami VA and the university. And that's the reason why we had the MRI center for this. And as I said, if you're interested in doing work in SPRINT, it's either freely available or through us. Thank you very much. We'll take questions now.
I think that was a very clear and elegant review of this very important study. While you're all thinking of your questions, part of the hullabaloo in the news about this is that it's obviously making 120 the new 140, but there's been concern about translating this into the clinic, as I understand it, because the methodology of measuring the blood pressure in clinic is usually they come in, they get their blood pressure measured, and a decision is based on that. Whereas with this, the patient had to sit for 5 minutes. It was repeated several times. Clearly not something practically done in the clinic for most busy practices. Is that a real concern, and are there others that we should be wary about in terms of understanding this data?
Well, well, it takes only 5 minutes. You know, I learned how to do the procedure to measure the arm, get the right cuff, and measure the blood pressure in my patients. I help the study coordinators. They laugh about that, but I help them. And it took me 5 minutes. It doesn't take really a much more time to prevent one event, in my opinion.
The other point that I before. Patients have to be sitting in a quiet environment. I know that might be challenging in our clinics, but those are the other two aspects that we have to take into concern. The other thing is that, I had frequent phone calls from the clinics downstairs at the VA saying, you took the blood pressures 120 over 80, but I took the blood pressure with my one time, and it was 150 over 80. So we had frequent phone calls about that, and obviously our instruments were calibrated often, so I would tend to believe our instrumentation.
Let me comment about that too. One of the problems in the clinic, because I see that every single week, is that the patient come in, as you described. They sit there, the patient is talking on the phone, the nurse is talking to the other nurses, they're interviewing, doing the med reconciliation, and they put a cuff that most of the time is either too big or too small. That's why those situations happen in the clinics, here and in the VA.
So there clearly needs to be an effort in that regard in terms of how we measure blood pressure in the clinic, regardless of how we apply this data. And I think that we need a lot of work yet in that area.
Oh yes, there is, and that's why they use 3, and they take the mean of the 3. The variation between those, it ranges about 5 millimeters of mercury. The more frequent you do, the less the variation will be. But Andy, in the study, everybody used the same methodology, the same rule to measure the blood pressure. So even if you have variation, right, it will randomly would be distributed between the two groups, right?
First of all, I congratulate both of you for presenting clearly an extraordinarily difficult study. This is quite complex, and it'll get more complex as to dissect it down. The issue on taking the blood pressure is crucial, and not only was it done the way Leo described it, but it was unobserved. So that, I just personally went through some non-medical evaluation where I was sat in a chair, cuff slapped on, the button is pushed, the thermometer shoved in my mouth, and the nurse was talking to it. And unfortunately, it was normal, not 300 over something. But, this is what we do, and that has to change. Secondly, the lower the baseline blood pressure, the more difficult it is to demonstrate a beneficial effect. And Sprint did this. And this is, an astonishing result from an NHLBI-sponsored study. This is superb. It worked.
Is there a question? No, it is.
I'm giving grand rounds.
Okay. All right.
Yeah. So, excellent presentation. Thank you very much for sharing that data. This two concerns I have. One is the population of CKD, where you have some studies that show that when you diastolic go below 70, you tend to increase the worsening of the CKD rate. That's one thing in the elderly means. The same thing in the elderly, there's some studies that show, and we talked about this, and maybe I'm going to get an answer regarding this. I know there's an MRI part, but when you talk, studies when they do pathology of the brain, in the 80s, where actually the main risk factor for Alzheimer's is normal population. I know if you have some information.
Well, I think that the kidneys are more sensitive to fast lowering of the blood pressure. There's no doubt, and the spring is showing that. But if you look at the spring, in the CKD group, there was no difference really in the CKD outcome. It was in the group that had normal GFR, because they have more reserve. And now we know and data is coming out, that is reversible. It's reversible. In the way that we practice, at least in the way that I practice with the A's and the ARBs and the diuretics in my clinic is that I go slow with them up, because I know that the patients are very sensitive to changing them then. And then I also don't follow the recommendations sometimes that you hear from cardiology that you need to maximize the dose. If the losartan is, the highest dose is 100, you need to push it up, because a lot of patients benefit from lower amount. That's my comment about that. The cognitive.
The
you wanna
cognitive
say?
function, we do cognitive function yearly, and hopefully we can do the 5th year cognitive function. But after that, we're going to continue to follow passively the patients to look at Alzheimer's, to look at other events once the study has ended, to see if the 3 years of intervention actually did something long term. Anecdotally, I'll tell you that I didn't see it. I did see lots of patients decreasing their cognitive function, but I think the majority of them were in the standard arm. So, but the paper is being written right now. I haven't seen the results for that, but it should come out soon.
Well, we're out of time for questions, but if